More seamless, Maria.
We're live now, Maria, by the way.
Oh, we are. Thank you. Good evening, everybody. And how many members from the public do we have tonight so far?
4.
Out of curiosity, 4. Okay. Well, I'm hoping we get some more. We did consider canceling the meeting and having Dr. Murthy come next month, but I decided let's move forward because Joe's not going to be here tonight. So I'll do my little spiel. Good evening, everybody. Welcome to the Housing, Health, and Human Services Committee meeting. If this is your first time being here, out of the 4 public attendees, welcome. My name is Maria Ortiz. I'm the co-chair of Housing, Health, and Human Services. Joe Rasuch is my co-chair, but he's not here tonight. So this is the April 2021 meeting. Per the governor's order, we can have meetings remotely. This is being recorded and it's going to be on YouTube, living on the internet forever. And the agenda, and I personally encourage people to sign up for the e-blast and the link for the documents because you get them beforehand. Just really quickly, process about the meeting. After the presentation we have tonight, first the committee is going to speak and ask questions or make comments, then the members of the public do. Subsequently, the discussion goes back to the committee. Second thing is sometimes on agenda items, committee votes to write a letter of support or make recommendations on different things, which it should be on the bottom of the screen. And if you're on the phone, I don't know if anybody's on the phone, it's *9 to raise your hand, *6 to unmute. I hope that was clear enough for everyone. And we're just going to jump right into our first item, which is about maternal mortality. And just very briefly, some background. Because we actually had a health disparities forum at CB4's. Mortality was one of the items we were supposed to be discussing, but we weren't able to in the depth that I thought was needed. So we're having it here this month. Dr. Amita Murthy, she said I could call her Amita, is an OBGYN. She's been practicing for almost 20 years and is currently working with New York City Department of Health on the Maternal Mortality Project. And I'm looking forward to hearing everything you have to say, Dr. Murthy. So you can jump right in.
Great, thank you so much, everyone. Good evening, and I'm happy to be here. I think Nellie, I have a slideshow. I think Nellie is gonna start sharing that. And thank you, Nellie, for sharing that. Oh, I didn't update the date. Sorry about that. Great, so we'll just go straight to the next slide. So I'm going to be doing an overview of New York State pregnancy and mortality, as well as New York City pregnancy, mortality, and morbidity. This quote actually is from someone at University of North Carolina, and I feel has grossly mischaracterized the work that OBGYNs do, but this is how it's been characterized. And the quote is that the baby is the candy, the mom is the wrapper, and once the candy is out of the wrapper is cast aside. Next slide. So maternal mortality in the United States, while decrease is increasing as compared to other developed countries. And you can see here that this graph shows a lot of countries within the realm of Europe, as well as Canada and Australia. And you can see that maternal mortality there is decreasing. This data goes up to 2015. There is slightly more recent data, which I'll show in the next slide, please. So New York State surveillance has shown that there's been the number of reported maternal mortalities has increased over time from 15.4 deaths to 19.6 deaths per 100,000 live births. 66% of the prenatal related deaths in New York State involved a cesarean section.
Huh?
Yeah. So cesarean section is a surgery just like any other surgery, and so there is the likelihood of complications from there. The top 5 causes of maternal pregnancy-related deaths were embolism, hemorrhage, infection, cardiomyopathy, and hypertensive disorders of pregnancy. That data is from 2014, and 2/3 of pregnancy-related deaths occurred within a week of the end of pregnancy. Next slide, please. When we look specifically at New York City surveillance, New York City has conducted enhanced surveillance of pregnancy-associated mortality and maternal mortality, as well as maternal morbidity since 2001. So pregnancy-associated deaths basically are identified using multiple sources, which include death certificate, linkage with our vital records, hospital discharge data, autopsy reports. We also have now been able to obtain further data from the fire department, which has EMS records, as well as starting to get more linkages with other data sources like Medicaid data sets. This data is compiled, and then there are obstetrician abstractors who then report case narratives, and then there's a M3RC committee, which is Maternal Morbidity and Mortality Review Committee, that meets and reviews all the cases. We have posted our recent data from 2011 to 2015 on the New York City DOHMH website. Next slide, please. So when you look at pregnancy-related mortality, the blue dots are the United States overall pregnancy-related mortality, and you can see that New York City, which is in the gray boxes, has sadly in a slight uptick when compared to the United States. Next, our most recent data publication, which covers data from 2011 to 2015, what we see is that pregnancy-related deaths among Black women were primarily caused by cardiovascular conditions, embolism, and pregnancy-induced hypertension. Pregnancy-related hemorrhage accounted for 12% of all pregnancy-related deaths, again, mostly in Black women. And what we'll see is that the pregnancy-related mortality ratio actually did decrease 44% from 2001 to 2015, but there's been no change since then. And then when looking at locales, the Bronx had the highest pregnancy-related mortality ratio, and Manhattan and Staten Island the lowest. Next slide, please. So let's look at pregnancy-related mortality by race. And again, you'll see here that the highest columns are amongst Black and non-Latina women. And even though there is a decrease in the most recent data of 2011 to 2015, you'll see that it still outstrips by far the number of deaths that you see in either white women or those of Asian or Hispanic or Latina heritage. Next slide, please. So we know that Black mothers are 8 times more likely to die from pregnancy-related causes than white women. Next slide, please. So we're going to switch over slightly to maternal morbidity. And you can see that maternal mortality here is really just the tip of the iceberg. And what you'll have is really what we don't see, and that is much, much deeper and a much bigger problem. Next slide, please. Is a life-threatening complication during pregnancy and childbirth. There are 25 at severe maternal morbidity in New York City, 2,500 women per 2008 to 2014. Next slide, please. However, the good news is that more than 95 out of 100 Black mothers actually do not have a life-threatening complication during birth. Is not a complication. Next slide, please. So again, Black women are much more likely to experience severe maternal morbidity than white women, and certainly much more than Puerto Rican or other Latina or Asian women. Next slide, please. Highly educated Black mothers have higher rates of complications than mothers of other races who did not graduate high school. Next slide, please. Here we're looking at SMM rate that, again, even those women who are considered underweight or normal weight still continue to have higher rates of SMM, and Black women still continue to have higher rates of SMM. Next slide, please. So having a chronic condition greatly increases the risk of severe maternal morbidity, which includes heart disease, high blood pressure, and diabetes, as opposed to, and you'll see the rates of SMM per 10,000 births compared to having no condition whatsoever. Next slide, please. You'll see here that the severe maternal morbidity rates by chronic condition, again, the highest rates concern diabetes and hypertension. We still have a significant number of SMM events in women who have a chronic heart disease. And then when you list any sort of chronic disease, the rates are nearly the same as just hypertension. Next slide, please. So what affects these rates? One thing that we've seen is that where a mother lives affects her chances of having an SMM event. And you'll see the difference between an area like Park Slope versus Borough Park versus East Flatbush or Brownsville. Next slide, please. If we were to look at where women tend to live and who lives where, you'll see that here you'll see the greatest number of white women live in Manhattan and Staten Island, which coincidentally have the lowest rates of SMM. Next slide, please. As compared to Black women who tend to live in Brooklyn, Queens, and in the upper reaches of the Bronx, which have some of the highest rates of SMM. Oh no, you can go to the next slide, thank you. If you were to see hypertension, you can see, again, the darker blue represents higher rates, and those higher rates of hypertension seem to coincide with not only where Black women live, but next slide, please, also the rates of severe maternal morbidity by district of residence. So again, the darker the orange, the higher the rates. Next slide, please. So what is it that's driving the inequity in maternal morbidity and mortality? And what we're seeing is racism and gender oppression. It's racism not only on an interpersonal level, but on an institutional and a policy level, and gender oppression overall in terms of sexism, misogyny, masculinity, and discrimination. What does that lead to? It leads to all of the historic and socioeconomic outcomes, including poor housing, lower incomes, increased exposure to violence and trauma, higher stress levels, poor access to resources, poor distribution of infrastructure, police profiling, disrespectful care, and increased risk of incarceration. One method that we are using to try to at least change disrespectful care is the New York City Standards for Respectful Care at Birth. Next slide, please. And basically using community voiced input, the DOHMH, along with community voices, came up with these standards for respectful care at birth. And they lay around the areas of education, decision-making, support, informed consent, quality of care, dignity, and non-discrimination. These standards are posted in almost every single birthing facility within the 5 boroughs. They are available in 7 languages. We have them that you can print off the website for further information. And basically the idea is that we want to educate not only our providers, but our community members and patients that they have a right to demand the care that they want to receive. And if they feel discriminated or attacked in any way, shape, or form during their receipt of care, they have rights to raise that up and to be able to fight for those rights and their voices to be heard. This is a very quick overview of some of the stats around maternal morbidity and mortality. I'm going to end here, and I'm happy to take any questions. Thank you.
Thank you, Dr. Murthy. Oh, wait, I should be looking here. Thank you, Dr. Murthy. Before I go to the committee so that they can ask their questions, I wanted to ask you, there's something that you just mentioned, respectful care at birth, I think, the last flyer you just showed.
Mm-hmm. Yes.
And I'm curious, how did that come about as a flyer or a recommendation? How did that? Yeah.
So about, where are we in 2021? I want to say about 4 to 5 years ago, one of our units within the Bureau of Maternal, Infant, and Reproductive Health received funding to actually just poll the community around issues of concern. When those results were tabulated, they held multiple focus groups and listening sessions amongst many different community groups and community members. And the results of those polls really showed a concern around what we're now calling disrespectful care at birth. It's also known to be called obstetric violence, or concerns around discrimination. And so we being the DOH then applied for further funding, and we created a core community group called the Community Support Group and Community Education Group. And together with those groups and the DOHMH, talked over and got further details around their concerns around obstetric violence and disrespectful care, and polled them for concerns around what they felt we should do. And so after many meetings and many work groups, the standards were born. And so this is really driven by the voices of the community.
Okay. Thank you for answering that.
Yeah,
I am going to allow Katie to call on the rest of the members who have questions, because you can see them.
Yes, I can. And I see Leslie, your hand was up first.
Thank you. Thank you, Doctor, for the presentation. It's very informative. I have a question. Now that you have summarized all of this information about the issue, what is being done on the educational level at the institutions that produces doctors to educate them to be more responsive and aware of how their actions impact the community? I know this is based in New York, but I am sure that this is also nationwide. So what is being done by the medical associations to make sure that the educational process also takes these factors in mind?
Absolutely, that's a great question. So we want to think about medical education at 3 concrete levels. The first level would be medical school. So the American Association of Medical Colleges, or the AAMC, which actually runs medical schools, as well as the LCME, which is the Committee of Medical Education, are working together to create a national curriculum around implicit bias, around discrimination, around decreasing myths around Black people, and many of those things along those lines. That is something that is very slow and will take a number of years. Many individual medical schools are doing something similarly, locally. So there's that work. There's then the resident education, which would be once a medical student graduates from medical school, they then get training in the specialty of choice. And so that is actually run by something called the ACGME, which is the Committee of Graduate Medical Education, or the American Committee of Graduate Education, or Council or something. And they themselves are working on something, but you have to realize that there's something like 20 different specialties that have their own individual boards and individual plans about learning. So they are working with all of the boards to institute that kind of learning during residency, which is where many medical students will find behaviors to model. And if there's racist practices embedded in the attending's behavior, then trainees will then perpetuate that. And then lastly, there's the post-residency or attending level, which would be where you work in a hospital or a facility. Many individual departments, depending on what specialty we're talking about, are working on anti-racist policies. Many hospital systems are working on anti-racist policies, but there isn't one national tie-in to bring this all together. Many localities are doing their own things.
Thank you, Doctor.
Mm-hmm.
Thank you. Josephine?
Thank you so much for this presentation and the important work that you're doing. Just a few questions. For the disrespectful care, is there a place where mothers can report any issues that they've been having? That's the first question. And then the second and the third question, I'm wondering, are there any programs that the city can offer in terms of providing stress management for women who are either going to become pregnant, thinking of becoming pregnant, or during their pregnancy, and also access to healthier foods, because some of the areas that you highlighted are food deserts, basically. So are there any programs, like maybe stipends, that mothers can get in order to get better quality food, even though they have to go out of their neighborhood to get it, but better quality food, before becoming pregnant and then during their pregnancy? Thank you.
Sure. So the first question, I now have forgotten what that first question was. I'm sorry.
Oh, no, it's okay. Is there a place where women can report if they've been disrespected? Yes.
Okay, so every hospital has what's called a patient advocate. And so they can report to the patient advocate. Obviously, many people are not aware of the fact that the patient advocate does exist. This is probably the reason why medical malpractice cases are rising, and there are high levels of litigation in that area. The standards themselves recommend that the patients can reach out to the Committee on Human Rights, or they can reach out to an attorney to have their voices heard. There are multiple surveys that are being given to patients within hospitals or who are discharged from hospitals, and this ranges from either activities that the hospital is doing to what's called Press-Ganey scores, which is a way for hospitals to capture the patient experience and try to improve that. But none of these really are well-established systems of reporting that in a standardized way. So as far as resources for women who are pregnant, the nice thing about New York is that New York State as a whole, for its Medicaid provisions, is very expansive. And so if a woman is either underinsured or uninsured, a pregnancy itself is an event that qualifies her for Medicaid. She's then also able to qualify for things like WIC, which is the Women and Infants Children's Program, which allows for improved food access and diaper access. She's also able to obtain food stamps and EBT and access other food banks as needed. That being said, we have noticed during the COVID pandemic that those resources have been in dire straits. And many of the WIC recipients or food stamp recipients have not been able to access things like diapers, formula, or food or medication, partly due to the pandemic and partly due to other things as well. There isn't anything further that women can obtain through state government. There may be programs within private insurers or within employers that help that, but there isn't anything, as far as I am aware of, that is, again, standardized for all women to know that this is something that they can do. 311 does have some resources around the food banks and WIC locations where women can go. But unfortunately, like pre-pregnancy, it doesn't, if they're underinsured, it doesn't help.
I just wanted to clarify, thank you for that. The first question about the disrespectful care. So you're saying that if a woman is treated poorly or feel that she's being treated poorly at the hospital, she has to go to an advocate at the hospital, or
yes,
just a private lawyer? Okay, but
no, there is an office in every single hospital. It has a different name in every single hospital, but it's generally a patient advocate who will then is basically a third party person who's outside the administration of that department, can take the complaint and then deal with the ramifications. Again, that's more of an internal hospital process.
Right.
And doesn't necessarily guarantee that it won't happen again to someone else. Nor does it change the behavior of that particular provider.
Okay, but there's nowhere to report it within the Department of Health.
No, there is a New York State Department of Health website that they can go to report these things, and that has all facilities. New York City DOH does not have any regulatory authority, so we can't take reports like this, but New York State Department of Health can.
Okay,
you also mentioned the New York City Commission on Human Rights, right?
Yes.
That people can
You
also.
can take those reports as well. Yes.
Thank you. Paul, did you have your hand up earlier?
Yes, I did. Yes. Doctor, thanks for the information. It's always shocking to hear about these numbers. These are scary stats. I wanted to ask a couple of quick questions about just about the statistics that you quoted there. I've always been shocked to find out the United States has such a relatively high mortality rate among pregnant women. And is there any magical sleight of hand that can manipulate the U.S.'s standings internationally? I mean, by which I mean to say, is this a problem that you can deduct? These are shocking numbers for women of color. If you take those numbers away, my guess is that the United States still does not have a very good standing on this chart. Am I correct? I was afraid of that. It's horrible. Has anyone picked them apart yet to come up with a reason for that being the case? We all know that, unfortunately, in our healthcare system, we seem to spend the most and get the least curative care. Has anyone attacked this particular fact from that angle? It doesn't sound like there's any way to make the United States move up that chart by simply not looking at any part of the picture, any part of our vast and varied population. That seems to be the case? Is that true?
I think people have attacked these problems in slightly different ways. There is, the one way of looking at one particular problem, such as evaluating all of the things that cause maternal mortality and trying to fix those things. There's the other way of saying, okay, the United States healthcare system is fractured. The way a person has to access care is very difficult and different. So why don't we try to manipulate how care is accessed? So that would be the reasoning for Obamacare, for example. That would be the reasoning for Medicare, Medicaid, for example, to try to remove cost as a barrier. But in reality, until we can fix many of the structures within the United States, not just New York City, the historical structures that have led to differences in areas, that have led to redlining, that have led to differentially investments in infrastructure and in education. That's a much bigger and larger argument and a larger effort. And I think we're even trying to argue about infrastructure, and we can't decide what infrastructure.
Well, thank you for bringing us some shocking numbers. It's always a horrible thing. I have one, if I can just sneak in one small technical question. You mentioned that one of the major causes of mortality was embolism. I quickly Googled just to refresh myself. So an embolism can be a fat globule, it can be a clot, it can be a foreign material. Is there any one kind of embolism that causes maternal mortality?
Yes. So pregnancy in and of itself has an increased risk of blood clot development. That would be things like DVTs, pulmonary emboli, or other kinds of clots. It really has to do with deep vein thromboses leading to pulmonary embolus. But there is a very, very small risk of death from something called an amniotic fluid embolus. It's a very rare complication, but a very severe one.
Thank you very much.
Thanks. In fact, Paul, but I noticed that this week is Black Maternal Health Week, which I think is awesome that was announced, and I saw that the White House has released several recommendations around these issues. And I just wondered and I know it was just 2 days ago or something, and I wondered if you had a chance to look at those recommendations and if you think that they at least go some distance, even if they don't do enough, or if you sort of feel like, well, no, it's not really much of a good starter there.
Right. So unfortunately, I haven't seen the entirety of the roundtable discussion that Kamala Harris had with her panelists. So I don't know the recommendations from her end. I do know the governor himself released recommendations early this year, late last year, sometime, fairly recently within the last 6 months around improving maternal mortality within the state. And because Melissa DeRosa was the head of a committee and a task force that came up with possible recommendations and actions that the state can take to try to deal with the problem of maternal mortality. Some of those recommend increasing access to midwifery care. Some of them have to do with expanding the time period that Medicaid covers a pregnant person postpartum. Right now, coverage ends after 60 days, but we want to extend that, or the recommendation is to extend that to a year. I believe that's sitting somewhere in Congress. There were some other things around, in order to increase doula capacity, we have to increase reimbursement to them. So there's some pilots around that. But there's really, and again, different bias and racism, which was another recommendation that the committee had.
Yeah, and I do see on the White House one that they say investing $200 million to implement implicit bias training for healthcare providers.
It has been something that's been slowly gaining traction within New York City.
Okay.
It hasn't really worked well for the obstetric medical home. That's something that New York hasn't. But medical homes in general, in terms of primary care, have been working and have been successfully. Don't know. There is one in your district. I'm not sure where it's housed.
Okay.
But there is a medical.
Your data looks like it's. Do you have a sense at all from what you've heard differently, or are those trends that you showed us from 2015?
OHMH has published some data that ends in 2017. It's not as detailed as some of these infographics, and certain of the infographics take into account data up to 2017, and certain of them don't. From 2015 to 2017. We're going to need at least another 2 years worth of data. You'll see that we're grouping them in like 5 years worth of data, and we tend to see we get better data over 5 years than we do over 2. But there's been an update that is on the New York City DOHMH website, but it's all really difficult to read graphs, which is why I did not include it here. It doesn't project well at all.
A couple comments. First of all, thank you, Dr. Leslie, talking about educating doctors. My cousin is an OBGYN doctor and be addressed. Doctor, we're a community board here. We're a small community board, Chelsea, Clinton, MSS. The highest rates are, I can't solve toxic racism or toxic masculinity or all this. What can we do now here to restrict? And if we do, what can we do now to get your information to the hospitals? What specific, as a community board, we're limited in our powers, but we can get out information we need.
Dr. Murthy, can you actually share the CB4 information you have?
Yeah, I actually, I had to send the updated version because so yes, your numbers, particularly in your district, are small, but the numbers of the issue being that the number of women that actually had an SMM event for which we can calculate are small. So we're looking at smaller and smaller numbers for your particular district.
All right.
The issue is, of course, the things that you can do as a community really have to rally around, you're not going to be able to change the way Roosevelt or Mount Sinai educates their physicians. You're not going to be able to change the way they educate their medical students, but you have to change what's available within for your community members and for those who come from outside of your community members to deliver there.
But we can reach out to the hospital and we can say, we'd like a meeting with the hospital to discuss these issues. We can engage with the hospital.
Which is exactly what I was going to say, that's what you need to do, is engage with the hospitals. Okay. And really the best thing is usually every single hospital has a community advisory board. So your community board needs to reach out to that CAB and figure out what they're doing and how they're working together, because the funding for the hospital community advisory board is usually very small or comes from an auxiliary that does fundraising. So, and often will not have anything to do with city or state government. So coming together and working with the hospital's CAB is one way to ensure that they are looking at things that affect your district.
That's great. What hospital would that be for us here? If you don't know now, we can find out.
No, the biggest hospital that I know in that area is Mount Sinai West, formerly known as Roosevelt.
Okay.
So I would definitely focus on Roosevelt. The other thing that you would need to focus on is the smaller outpatient center that St. Vincent's is developing. Even though it's a little bit south of your community, a lot of your community members will be going
We'll go there. Okay. Thanks, Doctor.
Yeah, sure. And then if you want to go a little bit further north, you'd have to speak to Columbia, because within Columbus Center, they have a huge outpatient center.
Yeah.
And so you want to talk to Columbia because the patients that they see are from your community.
And what about, I'm sorry I don't want to take too much time, Doctor or Maria, but what about reaching out to our representative, Dick Gottfried, who is the head of the health committee up there? Should we reach out to him and say, look, we need more blah, blah, blah?
Absolutely. So that was my next suggestion, is definitely speaking with the members of the city council. I will also say that the local House representatives for certain districts within New York City have been extraordinarily interested in the problem of maternal morbidity and mortality. Specifically, Nydia Gonzalez, who actually represents an area of the Bronx, but she is working with members in the House around that.
But we would write to Dick Godfrey because he's our rep. And what would we say to him? What would we ask him to do? If you don't know now, but communicate to Maria so.
Right, absolutely. I'd have to think about what exactly would be the best thing to ask for, because asking for support is very easy, and that's something that anyone can glibly give you, but for actionable items is a very different story.
Right. That's great, Doctor. That's what we need, what we can do specifically for the women in our district. Thank you, Doctor.
I will say that the Momnibus bill that I sent information to Maria about the Momnibus bill, which is a national bill that's sitting in the Senate. It's passed the House, it's sitting in the Senate. There are aspects of it that are contributing. Part of that $200 million to implicit bias training is actually part of the Momnibus bill. So there are definite things, part of that bill, that could directly affect funding within New York City to affect some of these actions. So there's definitely ways to at least increase support for that bill that will get us funding, because everything in the end is dependent on funding.
So we can reach out to Nadler, who is our congressman. We should reach out to him. Okay.
Yeah. And then also whoever represents you in the state Senate, because Andrea Stewart-Cousins is, well, her Westchester district is more focused on abortion care, but she is aware of women's rights and women's health. And now that she is the chair of the state Senate, she's another important person to ensure that these things get pushed up.
That for us, that's Brad Holloman. We can certainly reach out to Brad and say, do something. Thanks, Doctor.
Yeah, absolutely.
And Betty, I saw your hand up.
Oh,
Betty, you're on mute.
All right, get all excited, you know. Thank you for your wonderful presentation. It was very informative. And I was wondering if anybody has tried or studied the effects of, or maybe not, programs that start with the pregnant woman, I don't know, 6 months before the birth would happen, and help them to be less stressed, teach them some ways to relax, all kinds of, I'm sure, medical things that I can't even think of, but that would lower their risk rate when they do give birth to the baby.
Yeah, so there is a national program called Nurse Family Partnership that we at New York City DOHMH support. And that is a 2-year program. So it's directed specifically at first-time moms who live in one of these heavily, I'm going to call it disenfranchised districts. And it's a home visiting program. So it's a nurse who is educated in pregnancy as well as the socioeconomic determinants of health, who then works with this mom for 2 years. So starting at 28 weeks of pregnancy, and then works with them through delivery, and then 2 years to try to help them with problems like this, as well as try to raise them up above that particular socioeconomic area. It's been very successful. Currently, it works very well, and there's a lot of data around the nurse-family partnership, and it works very well face-to-face. The pandemic has actually changed the way that they interact with their patients, and it's much more virtual. And I would say that all of the nurses who've been working on that program have said that they themselves are dissatisfied with the virtual platform, as well as their clients are equally dissatisfied with the virtual platform. So that is one program that definitely has has shown and demonstrated some help. And then we have some other home visiting programs that help as well, but those are more focused on the newborn after the newborn comes home and helps with the newborn. We were able to decrease New York City's infant mortality rate greatly with those programs.
Would those programs be something that what JD was raising, going to our elected officials to get more money for those programs?
Absolutely.
Okay, there you go, JD.
Yeah, I know that there's a number of shelters. I don't know how many of those shelters house women, but one of our home visiting programs is directly related to women who are pregnant in the shelter and families who live in the shelter. And so that is one program that we could definitely use funding for. Nurse family partnership we could use funding for, but right now our biggest priority is hiring. We can't keep our nurses on staff.
Is that because of the pandemic, or they're sick, or why are?
Some of it is pandemic related. Some of it is payment related, sadly.
Is what?
Payment, salary.
Salaries. Oh, salaries.
Need more funding.
Well, maybe they need to be paid more.
Yeah.
Now, actually, Leslie, do you have another question?
Yes, I have one follow-up question, and I just wanted to know what the doctor's view of the outcomes relative to the status of the hospital, whether it's nonprofit or for-profit.
Are you talking about maternal health outcomes?
Yes. Yes.
Right. So Elizabeth Howell is a physician right now. I think she's at Sinai, who's done a lot of work in this area. A lot of her work is looking specifically at outcomes depending on what she calls heavily Black hospitals versus heavily non-Black hospitals. Her seminal paper that was published, I would say about 4 years ago, looked at public versus private and seemed to find that public hospitals had more events of severe outcomes, but that was then sort of stratified by the rate of chronic disease. So more women with chronic disease would end up going to these public hospitals versus private hospitals. And then when she divided it, her next paper, which was about 2.5 years ago, looked at what she called Black serving hospitals versus non-Black serving hospitals, and again found the same distribution of more outcomes in hospitals that she called primarily Black serving versus those that she called non-Black serving.
Thank you.
Katie, are there more questions?
I don't see any hands raised or.
I wanted to save my question. I wanted the committee to go first before I ask the rest of my questions.
Okay.
Just in case some folks asked questions that I had, like JD asked actually one. So Dr. Murthy, I wanted to just I have some questions that we talked about, some we didn't. When you mentioned some of the things that we could do as a committee, when you mentioned like what we could do at Mount Sinai, which we happen to have a CAB member, Leslie Williams is a CAB member there. And I was wondering, does that include clinics where there's prenatal care as well?
Mount Sinai is a full service hospital, so they do have in-house clinics, so on the campus of Mount Sinai.
Well, I was thinking of, because we have Ryan Chelsea Clinton, and they have OBGYN and
Right.
OBGYN in there.
Ryan Health is a federally qualified health center, so that's a slightly different system of delivering healthcare. And unfortunately, like even if you were to go to the CAB can't direct what the FQHC can do.
Oh.
So that is a different level of oversight that you would have to go to see who you can talk to. That funding comes from a slightly different source because it's a federally qualified health center.
I always forget that. Yeah.
Yeah.
Okay. And out of curiosity, what countries have the lowest maternal mortality and morbidity rates?
What you'll notice is that it tends to be countries that have what is popularly called socialized medicine. So they tend to have very high taxation and provide very many benefits. So we're looking at countries like Sweden and Norway. We're looking at countries like Australia. A lot of countries in Europe. Italy, we'll see. Italy also is sort of at the forefront of medicine in a lot of different ways. So they do publish a lot.
Okay. And I know that in 2016, New York State ranked 30th in the country. And I'm just, have we improved in that number? And I think the answer is that we don't have the data yet.
We don't have the data yet, but I don't think I think in their report from the task force headed by Melissa DeRosa, they seem to indicate that we were 30th or 31st. So we haven't changed.
Okay. And how, if you could make this answer kind of brief, in your explanation, how do you know when someone has died from a maternal death?
Right. So when someone dies, a death certificate is generated. On the death certificate, there's a little check mark, a checkbox that says pregnant or no. If that box is checked, that automatically flags our vital statistics office to keep that file aside for further review. And then they'll check and see if that actually is a pregnancy associated death. Every municipality has on their death certificate, not every municipality has this pregnancy checkbox on their death certificate, although the CDC that does collect national data is encouraging every municipality to have that checkbox.
That's interesting. I didn't know that either. And here's another question that I had for you. In New York State, I know that like 15 years approximately before the New York State Task Force convened on this issue, that the rates in the US, what I read was nearly doubled in that time frame. And I was curious about the reason.
So if you were to look at the data, let me just backtrack a little bit. Obstetrical care and obstetrical management has changed drastically from the time that I was a medical student to the time that I've been an attending. And things that I learned about in medical school are actually no longer done now in obstetric practice. I think that if you were to look at the cause of death 15 years ago, the most common cause of death was hemorrhage. New York State has done quite a bit of work around hemorrhage, particularly in the last 8 to 9 years. ACOG District 2, ACOG is the American College of OBGYNs, and New York State is its own district. ACOG District 2 has been working on something called the Safe Motherhood Initiative for about 10 years, of which the last 8 years has been really attacking the problem of hemorrhage, which is why now you'll see that the most common cause is not hemorrhage, but now things like hypertensive crisis or embolism or a cardiac disorder. That's because we've done, not only has obstetric care changed in that time, but there's been a lot of work done in treating hemorrhage, recognizing hemorrhage. Things like simulation and drills have been done in and around hemorrhage to improve that. So that's why we've been able to change that. In addition to that, we've had quite a few improvements in anesthetic care and anesthetic monitoring. And so moving away from general anesthesia for C-sections to regional anesthesia has been a big deal. Specialized monitoring during anesthesia provision has been a big deal in changing anesthesia care and how it's delivered. So those things, as well as just changes in practice, moving away from or moving back to vaginal birth after cesarean delivery, moving back to doing breech delivery, moving back to encouraging practices that were done many, many years ago and were no longer done, and moving back to some of the old ways is changing some of this care as well.
Okay, and thank you. My last question is the thing that, yeah, it is a question, a comment and a question. The thing that jumped out at me the most was that non-Hispanic Black women, I wrote it down, with at least a college degree had higher SMM rates than women of other races or ethnicities who never graduated high school. That really jumped out at me because I would not have expected that when I had learned that in the past. And so I guess my question for you as the expert is, just so I'm clear, it sounds like from everything that I've heard you say and that I've read about this issue is that the reasoning for this and the results of it are not so much individual as they are systemic. And I would like if you could clarify that for me. Are there some like individual reasons, if that makes sense?
Right. That's something that's really difficult to tease out. I think that it's very easy to identify interpersonal racism. It's very easy to try to identify the person that is racist and has racist behavior. The problem is that the bigger problem, and the thing that's harder to change, is when that behavior is not recognized and then not called out and not changed. And so we go from the person who is explicitly racist to the person who says, I'm not racist, I really am not, but in their behaviors and the decisions that they make in the care for this patient affects everything. And that comes from where, that's everything, right? That has to do with where, like, for example, if we're talking about me, that has to do with my privilege, where I came from, how I grew up, the things that surrounded me in my own experiences, and all of that contributes to that interpersonal reaction. The problem is that those experiences are so heavily weighted by the historical effects and the things that have happened within New York City and New York State and with Black and white people, that is something that is really difficult to change. And so yes, while it's easy to say, and we'd like it to be an interpersonal thing, what we have to realize is that in the end, all of the structures that are in place for education, for medical training, for all of this, have been put in place by white men. And because they've been put in place by white men, that has affected how women have been cared for, that has affected how Black people have been cared for, that has affected how Indigenous and Native peoples have been cared for. And we cannot escape that.
That was a really deep answer.
Yeah.
I wasn't expecting all that. But I know that's some of it, yeah. Thank you so much, Dr. Murthy. I don't know if there are questions from the public. Katie, can you see that? We took up a whole lot of time.
I don't. Oh, actually, I do see a hand raised. I don't know how to. Yes, from Maya Burlow. Nellie, can you bring her over?
Maya
Yes.
Burlow from Brad Hoylman's office.
Maya?
Thank you. I was wondering, follow up on Josephine's question, if the patient advocates in hospitals have any obligation to report complaints to the
Oh,
city
sorry,
or the
Maya,
state.
you broke up.
Oh no. Let me.
Heard about obligation to report those complaints?
Yeah, I was wondering if the office of the patient advocates in hospitals have any obligation to report complaints outside of their hospitals, either to the city or the state.
I think that would be set up as to how the how the hospital system has set up that office. For the most part, my understanding is that they do not have to report those things to the state.
Maya, that sounds like an opportunity for legislation.
That's what I'm thinking, Maria.
I will say, having worked in a hospital, there are certain things that, they are required, that hospitals are required to report on. certainly maternal deaths. There's a dashboard, there's something called NIPORTS, which is, there's a dashboard of reporting systems, and there are certain events that hospitals have to report on. It's really difficult to legislate something like this because, if, the patient advocate can deal with complaints as simple as the call center did not answer my call, which is not something that legislation can change, right? To a report of my midwife slapped me in the face. That's a very different kind of thing. So legislating something like that is difficult, but probably can be done.
Yeah,
Thank you.
of course it can, if there's enough will.
Yeah.
Thank you, Maya, for your question. Katie, was that it?
I don't see any other questions or hands raised.
All right, so full disclosure, I do not love writing letters, but I'm curious what committee, what thoughts you have, and if we should be writing one, or if this is something that we can deal with without writing a letter.
JD?
Well, I'm not going to write the letter because I'm a white man, so obviously it would be, I don't know if it'd be ironic or wrong.
So I have to write it?
I kind of resent that comment, Dr. Murthy. It's a big subject, and I don't think it can be reduced to such easy terms. But I definitely think we should write a letter to Brad and to Dick Gottfried with suggesting a lot of the things that the doctor suggested to get funding, like Betty said, and certainly what Josephine was talking about, to get some of this information out, and for Leslie to reach out to the Mount Sinai to start the ball rolling. And whatever the good doctor suggests that we can specifically try to get or try to ask for, I think would be useful.
All right, JD, so you are suggesting a letter.
I move that we, a non-white man, write the letter to our electeds, Dick Gottfried especially, and Brad Holloman to support the doctors, to support Senator, what did you say, Doctor? Which senator is working on it upstate?
Oh, Nydia
Andrea?
Velasquez?
Yes. Yeah.
To support the various funding ideas that are being worked on in Albany, and to whatever the good doctor suggests we should ask for. I suggest somebody write a letter. Josephine.
I'm happy to.
Wait, can I
Oh, sure, go ahead.
Let me just jump in. Just to be clear, none of this is personal, JD.
I'm sorry, Maria. I'm
can
sorry.
I finish my sentence, JD? Let me just finish my sentence, my thought, please. That none of this is personal about us specifically, but if anything, I feel it's personal to me. It's personal to Josephine, because we're Black women we're women of color who have children. Sometimes I think I say I'm Black because my father has roots in Africa. And there was another thought I had. I'm sorry, I just lost it. But to be frank with you, you do write really well. So I think I would need your help writing it. And I would appreciate your help writing it.
Sure, I'm glad to help, but
I think one thing I'm going to say is that I'm going to apologize for any offense that I may have given in any way, shape, or form. But this is the reality that we live in and the times that we live in. And speaking from history to now, we have to take into account not just of color, but of misogyny as well. So, but it's hard to speak about that, and it's hard for people to not take offense. And I did not mean that in any way, offensive way at all.
I know you didn't, Doctor. I understand that you didn't. I did not take offense from you at all whatsoever. However, I am just a volunteer community board member trying to do what I can do here and now for my community. I can't solve all the problems. And to be stigmatized as a member of a group, you can't help but say, hey, wait a minute. That's, you
No, I
know.
get that, but just to be fair, when I said that medical traditions were built by white men, I'm thinking about 1880 and not 2020.
Right. I don't think anybody on this board was being stigmatized directly. That's certainly, I don't think that that's the case, but these are things that we need to talk about. So, Doctor,
I'm
thank you
happy
for
to
being
talk
so
about
frank.
it. I'm happy to talk about it individually, but I'm on this community board to try to solve problems.
Yes,
not
and we're
to
going to
get
write a
in-
letter. Yes, thank you. And you made a recommendation to write a letter, and JD, that's very helpful. So we can work on drafting one. I'm happy to work on drafting one and
Right.
run it with Maria and JD's help.
Yeah, Josephine, can we draft it and then we'll have Joe, and then I'll send it over to JD
Of
to make
course,
edits? Okay.
absolutely. Yep.
And can I ask a quick follow-up? So there had also been the suggestion about that you'd made, Doctor, about us reaching out to the community group at the hospital. And so I think that sounds like that's separate from a letter, right? And I'm not sure sort of how we as a group do that. Do we agree, or Leslie, do you give us some advice on that, or how does that work? Because I know you serve on that.
Well, I deal with Brad at the hospital as part of the CAB. So I would reach out first to Brad and broach the subject with him and what we want to do. And possibly we can set up some sort of a meeting in which we can discuss this, you know, as a group, as to whoever may be interested, Maria. What do you think?
I wanted to ask you, while you've been on the advisory board, have you had a presentation by an OBGYN? When I was on it, we did, but I'm curious if you've had it.
Not to my knowledge, no.
Okay, so yeah, maybe linking with.
Well, we wanted to get that one lady, if you recall, but because of timing, we couldn't get her. Do you remember for the other meeting that we had a few weeks ago? But because of scheduling, she wasn't able to present at our session that we held.
Oh, you mean at the task force?
At the task force meeting, yes.
Right.
So there was going to be one, but she, you know, would have been presenting to us.
Apologies, Maria. You have a motion that is in place. We haven't had a second.
You know, I can't see. Thank you.
It's okay. You don't need to see me. I'm just saying that we have a motion. No one seconded yet. And then we can have discussion after that. Thank you. Now seconded. Now you can continue discussion.
Thank you. What was I saying? Oh, my last thought, Leslie, was that yes, we can collaborate with Mount Sinai. I feel like I need to have another conversation probably after this meeting with a few folks to figure out what's the best way to do that, including with you, but
sure.
So I think we could vote on the proposal that the letter go out to the appropriate people, and that we also have a separate action. It's not a letter to Mount Sinai West, and that would sort of clarify things, I think.
Yeah, and my question, actually, my next thing, Betty, I was going to ask if you were actually taking notes for the bullet points. If not, I will listen to this meeting since it's going to be on the internet anyway.
Sorry, I didn't take notes tonight. It's kind of been a long day.
Well, I took some notes.
And I've got some notes too I can share.
I accept Betty's friendly amendment.
Yes.
So let me just mention, can I just quickly mention what I have so far anyway? I mentioned what I have, little quick words that need to go into the letter. It was, I wrote City Council, Momnimus Bill, I wrote Nadler, Brad Hoylman, increasing funding for visiting nursing services for pregnant women, a letter to Dick, also including Dick Gottfried, and supporting the New York State with the various funding ideas that that they have. Those were the things that I wrote and that I heard JD mention, as well as
and anything else the doctor would recommend, Maria, if you get in touch with her.
Yes, I know. I was thinking that as well. I'll get in touch with Dr. Murthy afterwards as well. Is there a motion for this letter?
We did it.
I made a motion
you
and I
did. That's right.
We
accepted
seconded it. So
Betty's,
now we can vote on them.
Betty's,
Thank God we can vote. All in favor? I can't see. I'm hoping. Oh,
Aye.
Yeah, I can see.
It's unanimous.
And it looks like I see all hands up.
Yep.
Yep.
all hands up in favor. Okay, so I don't need to ask about the rest. Moving on to, thank you, Dr. Murthy,
Yeah.
for your presentation. Thank you for being here, and I will be in touch with you probably tomorrow.
That sounds great. Thank you for the opportunity, everyone.
Thank you.
Thank
Dr.
you.
Have a wonderful evening.
Too.
New and old business, 2 updates for old business, but before that, I am going to email committee and I wanted to get, I'm letting you know so that when I send you the email that you have some ideas in mind. I wanted to have a little bit more often health-related topics. And so I'm curious what ideas you all have. So I'll send that email out tomorrow or Monday. An informal, I wanted to give an update about the HKNC meeting with NYPD since committee wrote a letter about that. I'm just going to give a few highlights, and then Dolores or JD, if you want to add. The meeting was, I forgot when the meeting was. I feel like it was in March. Dolores, it was in March?
I'm sorry. Which meeting?
The HKNC NYPD meeting.
It was probably in the last week and a half.
Am I? All right, I apologize, folks. And for me, in my mind, it was many, many weeks ago. But it was Midtown North was there, Midtown South, the 10th, 13th, and Midtown South Command. Just some highlights that I thought were super interesting is that even though there's supposedly a reduction in crime, actually what they're noticing, what the officers are noticing is an increase in violence, up 66% in Midtown South. Shootings have increased, up in burglaries. Something else that was mentioned was 92% increase in 311 calls, 311 homeless calls. 911 narcotics calls have increased, especially around, not surprisingly, between 34th and 44th Street on 8th. The other 2 major things I just wanted to mention, 2 chiefs in the meeting mentioned that was super important to know who your NCOs are. I forgot what that stands for. Neighborhood community officers, I think. And it's also very important, they mentioned to know your youth coordinator officers. They really honed in on that and stressed that. I didn't realize how significant and important that was until they were mentioning it and developing relationships with them. They talked about joining the Build a Block meetings. The last thing I wanted to mention, what we talked about for next steps was more collaborations, and that another meeting would be happening in about 2 weeks from now. I don't know if JD or Dolores, if you want to add anything.
I'll just add one thing. The perception, there's a perception of things, and when you have a violent act, it increases anxiety in the neighborhood. This woman who was attacked, brutally attacked on 43rd Street, was attacked by a man who was on lifetime parole, who had killed his mother, and was released from jail, and for some reason put in one of the hotels in our neighborhood. And so the question came out, why wasn't this man receiving mental health support? Why was he put in a shelter? Was he put in the shelter with the proper supervision and support? So that, I think, was a legitimate concern that people have, and that increases anxiety, what can be done about that. And I think Gail Brewer also said, yeah, that is a problem. People need help. You can't just put people in a hotel and not give them the support they need.
Yeah, and Gail Brewer also questioned the reason why someone who was released from a state facility was in a DHS shelter site. Also, I forgot to mention that in the meeting, there were elected reps from every office, from Nadler to Gail Brewer, every level, including Gail Brewer was present. Anything else, JD, that I'm forgetting that's significant from that meeting? I think that's
yeah, I think the outcome was also the Department of Homeless Services does not communicate well with our neighborhood or with our precincts. And I know Maria can speak to that. And it was a request that they communicate better. Let us know who's coming in. If you have some parolees who have a violent history, let the precinct know so better monitoring can take place. So I think it was an attempt also to get the agencies to communicate with each other better.
And at the next meeting that's supposed to happen, actually DHS is supposed to be present. That's the plan.
So Maria, the only thing I would add to both your report and JD's comments are not just the communication, but one of the issues is it was made very clear that NYPD, as we already know, no longer handles homeless issues.
Right.
But when we as citizens see someone in distress, our first call is always going to be 911. And because NYPD is an agency which is available 24/7, they can respond in normal times prior to the pandemic. The Department of Homeless Services has the lead on any homeless issue. They're not a department that is set up to operate 24/7 or have a call center like 911. So we recognize that this policy change is having a direct impact, and it's amplified in our neighborhood because of the many relocations. So communication is one part, but I think it is also important to recognize the outcome of different policies. The other policy that was brought up that has been creating issues is how bail reform is being interpreted by certain judges. Cops are finding that there are many folks coming and preying on these vulnerable populations in our community. They're a lot of them are drug dealers. They're caught, they're brought in, and then they're released. And there were reports of folks that have been taken in more than 200 times. But because judges are just blanketly, in some cases, just not paying attention to the fact that this is a recurring criminal activity, we're continuing to keep our streets full of predators. And essentially, these are not the same as the folks that are in our homeless shelters. So there's a lot of complications. It's going to take coordination of agencies and also of our electeds to think about how to modify some of the policies that have been put in place recently.
Thank you, Dolores, for adding that. That was important. And I love your hair tonight. It looks beautiful.
Maria, can you tell us who was invited to that meeting and who is invited to the next meeting? It sounds like it was members of HKNC and the police precincts. And I guess you mentioned the electeds.
And elected.
Were there other community members or businesses or any other agencies present, or are any of those groups being invited to the next one?
So who was present at the meeting were community members, business owners, someone from, I forgot which, these two I'm thinking of, Hudson Yards Alliance, I think is the word, and
Hudson Guild is a member, the BID is a member, the block associations, the businesses.
When you say a member, you mean of HKNC?
That's
Yeah.
correct. And the garment
And-
district, anybody who wanted to, in the neighborhood was welcome to join. And then it was, you couldn't send everybody to the meeting. So we all voted on an agenda and a couple of us went.
And the meeting was being led by Gail Brewer's office. And they're the one who, they are leading the next one as well. And Gail Brewer was great, I must add. And I wanted to transition into the next topic, if that's okay.
Oh, wait, I just had one question, Maria.
Oh,
So-
I didn't see your hand, sorry. You know,
I didn't have my hand up, that's why.
Okay.
So in the letter, we had asked for to have a medical expert on mental illness and a homeless advocate. Were they not invited? I know this was
not at the first meeting. That was actually discussed for moving forward.
So the meeting wasn't focused on the homeless issue. The meeting was trying to understand perception versus reality in terms of crime in the area. Because again, the stats are showing that crime is down, but there are many folks that continue to come to the police precinct council meetings that are reporting that they are sensing that there's an increase in crime. And then in fact, there are additional incidents. So a lot of it was not focused on the homeless. The homeless came up only because of the fact that huge communication gap is one that we cannot ignore, is creating some of the issues that the community has been experiencing. So the focus was not on the homeless at all. The focus was trying to understand what is the reality in terms of crime within our community at this time.
Okay, I just brought it up because Maria had mentioned the letter that we did. So I thought that that was what this meeting was a result from that letter. And the reason I'm really pushing the whole mental illness, that Maria and I have had conversation about this, is that we want to look into what kind of services that are the providers actually giving to the people in the hotels. What are their social workers there? We just don't know. We know that there are some social services, but obviously not enough social services. So that's another conversation that, we can continue to have.
Yeah, and Josephine, I'm still prodding and probing some providers about social work interns and trying to coordinate a meeting.
Did we ever actually officially get a letter back or a response to our letter? Not HKNC's letter, so there's been that meeting, but to the community board's letter? I just don't remember.
From the letter that we wrote to whom?
So we wrote a letter in support of HKNC's generally, but then we asked for there to be a meeting. We asked for there to be a meeting that was focused on public safety issues, and at that meeting, there would be HKNC members, there would also be community board members, there would be the mental health advocates. We asked for that meeting to be coordinated. And so I'm just wondering if we ever got a response to that letter.
So in my mind, a response wouldn't be needed for that.
Well, we asked. I mean,
Well, we asked
were
for a
asking for a
meeting.
meeting. Yeah.
Yeah.
So no one responded, basically.
Sounds like it. Well, yeah.
Maybe I'm mixing something up.
Maria,
I'm not
I think
clear
the
on
best thing to
something.
do is to bring the question back to HKNC. And then,
Okay.
then you can let
No,
the
actually,
committee know.
or Jesse. I mean,
Right. They should have responded to the community board. It was
Why?
all.
Why is that, Josephine?
because
Why
the,
is-
commu-
About
the
something.
community board wrote a letter, and we're just
Right.
wondering if we as a community board got a response to our letter. That's all.
Usually when our committees write a letter to someone, they usually respond to Jesse at some point.
This is
Oh,
a
I see
group
what
of
you're saying.
block associations that were worried about things, and they asked Gail Brewer to set up a meeting. I'm finding this kind of a little overreach here. they have the right to go to their elected officials and say, we're worried about things. Can we have a meeting?
Of course, absolutely.
Absolutely.
As well they should.
When Maria brought up the letter, I thought she was talking about the community board letter. That's what I'm talking about. So,
Right. It's our,
Okay,
tell me,
so-
Josephine, so there was a letter, HKNC reached out to the politicals or the electeds and asked them to set up a meeting. And that's the meeting that happened. Awesome. What we're asking about is, does anybody here on the community board know if there's been a response to our request for a meeting? And it sounds like none of us know. So we'll ask Jesse.
right. That's easy enough. I'll ask Jesse. It's fine.
I just
So-
wanted to make a comment that I went to a meeting and I know that it's sometimes hard to follow up and get the information, but there was a police officer from the 30s, and he was talking about when someone brought up parking at the ACES meeting, he was talking about violence and vandalism that are happening to the police cars, that their wires being cut, their brakes being cut, their windshields being damaged and their cars being keyed and all this sort of stuff that was going on. So I just want to let you know about that. I don't know if everybody was there. So that was very upsetting.
So Judith, we had
Judith.
heard sort of,
Sorry,
Um,
let me just cut you off, Katie.
Mhm.
I didn't say this earlier. It's gonna be 8 o'clock. I was hoping we would be done before 8, so I'm gonna ask that we wrap up this meeting in 5 minutes. Okay? Because of another commitment that I have, but
Mhm.
can you, go ahead, now you can finish. what you were
Judith, I was just going to say, I think there've been a lot of reports from the summer about those incidences, but I was curious if what you heard at a recent meeting was that more of that or any of that had happened recently and in our district, or is that just reports of what had happened overall in the city over the summer?
Yeah,
was-
Katie, you're on the ACES too. Didn't you hear that? I think they said it was happening recently, and they're very concerned about parking, and they don't want to put their placards in their own cars because then they'll notify that they're police cars and they'll get worse. You were at that meeting.
Yeah,
Right.
so, okay. So yes, I was there, and I didn't hear them mentioning that any of that had happened recently. I was just curious, but we can follow up about that, because I think it was based on what had happened over the summer. That's all. Okay.
Thank you.
Hector, I see your hand up.
Right?
Yeah,
Some
actually,
people squatters, some people
you had already
didn't
mentioned
want
about
the
that previous
program.
meeting. Yeah, there was a lot of
Right, some people didn't want the
issues
program.
concerning
They didn't
safety
want
for the
the
officers
voucher
at the
or
time
anything.
because they were literally
Right.
getting their
When-
cars.
I
were
hear
being
two
trashed
voices
with
right
private
now.
vehicles.
If they want to leave
I'm
to
sorry?
development,
No,
they didn't want
let
it.
me tell. I'm sorry.
And we was trying to get them.
My daughter's on a class right now. I apologize. Basically, there was a lot of concern over the officers because they were literally getting their vehicles slashed and vandalized. Hence, that's why they were not putting their placards out appropriately. So there's a safety issue involved. And as far as some of the streets being limited access, I mean, basically, it's the same issue as well. I mean, things hopefully will change. They're trying to see if they can ease that up. They did say they were going to get back to us on what they're going to do about changing that aspect about the placards and also the closing of the streets. But in the foreseeable future, it doesn't look like it's going to happen anytime soon. At least till things calm down a little bit more and stabilize out there. So
Okay, so
there's
it
a
sounds
lot
like
there's a lot of apprehension about it. Let's put it that way.
Okay. Yeah, we can follow up. Thanks.
And before I move on to the last update about DHS shelter sites, I do want to mention for Josephine and Katie's question that I will follow up, and at the next meeting, I'll be able to provide clarity because I feel like I'm getting confused a little bit, and I apologize for that. I actually did bring this up. Jesse and I had a conversation, and he mentioned, since you had the HKNC, meeting with NYPD, you should, give an update. But I'm going to get clarity so we're not confused. And regarding DHS, I thought we were going to have our last meeting yesterday. It's actually going to be the next meeting is actually next Wednesday. But from the last meeting we had, and I don't know if I shared this with you all already, I may have, that testing is occurring on site. It's been happening for a few months. Vaccines are currently also happening on site. Did I mention this already, Katie?
I'll be honest, I've heard it before. I don't know if I've heard it from you or somewhere else, but so anyway.
Well, vaccines are happening on site. I know that started in March. And the thing is, I don't know is how often it's occurring. I'll find out more next week. What it sounds like is there are still, not surprisingly, there are still low rates of people actually getting the vaccines, because when the vaccines are being distributed on site, staff and residents can actually get the vaccine. But there's just a low rate of folks getting it. However, the
You mean
positive
because of
is,
vaccine hesitancy?
yeah, but the positive is that the rates are increasing slowly. Okay, the rates are increasing slowly. I actually spoke to Dr. Murthy about it, and she was confirming what I was hearing about the rates increasing slowly. In terms of the hotel shelters going back to congregate settings, there is no plan yet. So there's that, and I'm hoping maybe by next week to hear more information. I'm not hopeful for that, to be honest, but that's what we're going to be pressing for. And is there a motion to adjourn this meeting? Because it's 8:04 and I'm almost on time for 8:05.
I make a motion.
Thank you, Josephine.
Had that before.
Seconded.
We never had a partners meeting where we can address the problem with
Thank
the
you,
high
Hector.
ups, that you can go past the manager. That you can go
Have a
past
good
the
night,
manager.
everybody.
This
There
is
you
all
go.
that we set up.
Good night.